All right, good evening, everyone. Can you hear me? All right, so good evening, everyone. I wanted to welcome you all to this year's second presentation of our 2024 Evening Speaker Series. I wanted to thank our valuable industry partners for joining our event. The Nebraska Oncology Society would not be able to accomplish our mission without your partnership. And here is our agenda for tonight. And just to go over a few housekeeping items, we'll just ask that you please keep your cell phones muted throughout the event. We will have time for questions and answers after the presentation. And the event is also being recorded. So if you miss a section, you can always go back and review it. There is CME available for today. And for our event tonight, we are hosting a presentation by Dr. Abdallah. As the Director of Plasma Cell Disorders Care at the University of Kansas Health System and Chair of the U.S. Myeloma Innovations of Research Collaborative, Dr. Abdallah is primarily focused on managing and treating patients with various plasma cell disorders, including myeloma, AL amyloidosis, POEMS, solitary plasmacytoma, MGUS, and smoldering myeloma. Additionally, he runs many clinical trials regarding PCD and has developed a multidisciplinary amyloidosis program that involves nephro-oncology, cardio-oncology, neurology, and palliative care. His interest in myeloma began when he joined the Myeloma Institute for Research and Therapy, or MIRT, at the University of Arkansas for Medical Sciences as an assistant professor of medicine, working as a clinician and research sub-investigator in multiple tasks of the treatment of the protocol. Dr. Abdallah gained a solid foundation of knowledge in chemotherapy, administration, mechanism of action, HPC collection and infusion, engraftment, treatment of complications and toxicities, and management of expected side effects. Overall, Dr. Abdallah's passion for treating myeloma and plasma cell disorders stems from his desire to help patients navigate the complexities of these diseases and provide them with the best possible care. Through his work at the health system, the University of Kansas Medical Center, and USMIRC, he strives to collaborate with community oncologists to develop best practices and ultimately improve outcomes for patients. Welcome, Dr. Abdallah.
Thank you very much, and thank you for this long introduction. Thank you very much for everybody for the invitation here. And okay. Okay. I can use this. Excellent. I have no financial relationship to disclose, and today we're going to talk about the TCEs, or what we call the bispecifics. The major thing about this is really growing. This is a field that we didn't expect it's going to grow there fast, especially for myeloma. We're going to talk about the efficacy, the safety as well, and indications of treatment using it, and also the most important thing that really actually is causing anxiety, and maybe it's causing some limitations of treating myeloma patients with this in the community oncologist, the toxicity of these drugs. And I think this is something we have to acknowledge, how we can actually make sure it's available in community oncologist doctors instead of just restricted in academic centers. So today we're going to talk about the T-cell engagers. And I mean, the first thing is that this is actually what we call it, it's imitation of what CAR T can do. Using a bispecific, which have the two hands or two arms, that collaborates with the myeloma cells and bind it to the T cells that really majorly go ahead and attack the myeloma cell. Mostly we have a target, in myeloma, we have two major targets, the BCMA, which we'll talk about it, and the GPRC5D. 3 drugs got approved through that, the elotuzumab, teclistamab, and talquetamab. And these 3 drugs, I think we have really great results and great evidence about the efficacy, but we have also challenges regarding the side effects and the toxicity that we want to talk about. So first of all, we have to talk about the target. Why are these targets very important? What is the vital about these targets? The BCMA, or B-cell maturation antigen. We're all going to hear about it. We know one of the drugs that was initially withdrawn from the FDA, the belantamab, focus on targeting the BCMA, B cell maturation antigen. It's one of the tumor necrosis factor receptor family. It's present in about 95% of the time in the plasma cells, so it's very vital. But when you activate that, that causes proliferation and survival for myeloma cells. So in other words, if you deactivate it, you destroy the myeloma cells. So it's a very important drug to target it. But also, it's an important drug to be detected 95% of the time. When we use the initial CAR T cell was targeting CD19, it didn't have that much efficacy. When they switched the CAR T to BCMA, the efficacy went very high and the duration of response improved a lot, showing that it's the best targeted therapy. So now you can see that there's CAR T cell, bispecific, and some antibody drug conjugates, which is ADCs, are targeting the BCMA therapies. The second target is the GPRC5D. It's a membrane that is present in myeloma cells, and also it's unfortunately present in bone marrow and also skin and hair follicles. Why is that very important? Unfortunately, because of the collateral side effects that we'll talk about that can be caused by the bispecific for that. The mRNA of this GPRC5D is really abundant in the myeloma cells, but low in the other hematological. So it can be used as like a target for myeloma for the treatments in order to get it in remission. Now, before we start talking about how effective these treatments are, why don't we talk a little bit about the basics? The major basic we have is that what is the definition of myeloma or relapsed myeloma? The problem here is that every time you have a myeloma, and we ask ourselves our question, is myeloma a curable disease? The answer is not a curable disease. Every time you get the patient in remission, they will come back and relapse. That's the biggest problem. So we start identifying that we have a great treatment. Every time we have a great treatment, the patient go to remission, they relapse after that. So proteasome inhibitors like Velcade and carfilzomib came out, did really great job, but patients still were relapsing. IMiDs like thalidomide initially, Revlimid, and pomalidomide, patients still relapsing. And finally, the CD38 antibodies like daratumumab and isatuximab, patient was still relapsing. So we figure out that there is, unfortunately, a patient population that are treated heavily, and they have a very poor prognosis. And we call them the triple refractory or pentarefractory. So triple refractory comes from the fact if you're refractory to 3 classes of treatment, a proteasome inhibitor, an immune modulatory drug, or a CD38, the survival after that is about 9 months. So it's very short. If you're refractory to 5 drugs out of the 3 classes, then your survival is about 5 months. So you can see exactly that we have a big problem for these patients. We have great drugs that get them in remission, but after they relapse, which most of the time after the first relapse, 95% to 98% of the time they will relapse, these patients are going to have poor prognosis. We have a lot of difficult time to find the treatment. So there was some drugs that we use. They have a response rate between 20 to 30%, which unfortunately was not a very great response. So we came up with a big question, why we need BCMA-directed therapy. That was the reason, because we really need an effective treatment. So our institution, prior to this, we have a lot of CAR Ts and clinical trials and bispecifics and ADCs that we use and target the BCMA. We asked ourselves the question in pentarefractory patients who have a survival barely 6 months, what was the survival in our institution? And we found it was 12 months, which is a year. We thought that was still, didn't make any sense because usually they have a poor prognosis, these patients. We don't have any options. So we actually reanalyzed the patients. Those patients who got BCMA-directed therapy, like ADCs, CAR T, and bispecific, and those who never got it because they were never eligible for trials. And we found out the difference was 12 months. Those survived longer with the BCMA-directed therapy, showing that it really plays a role to improve the survival. So these drugs were really the key to actually improve the survival for these patients. So after that, we start seeing that the bispecific coming out, and we have newer drugs that got approved, which is the first one is the teclistamab. The teclistamab, as we talked about from the Majestic study, this study focused on the majority of these patients, 3 prior lines of therapy. All these patients receive the 3 classes of IMiDs, proteasome inhibitor, CD38. The issue about this drug, other than the side effects, which we'll talk about it is a step-up dose. That means requiring to be hospitalized, so they can give you a lower dose and then up it until they reach what we call the target dose. In this case, 1.5 milligram per kg. So you have to have 3 dosages. And the whole purpose of that is that they try to actually minimize the side effects. Cytokine release syndrome is one of the side effects. They want to try to minimize it to get to that direction. These patients were receiving this drug weekly, first week, they will admit to hospital, and then after that, weekly outpatient until they progress or they cannot tolerate the treatment. The main primary endpoint is that they were looking at the response rate more than the PFS and overall survival. So if we look at the results of the Majestic study, and it was really great, impressive, because we're talking about like heavily treated myeloma patients. Out of 165 patients that were there, the extramedullary disease, which have like very aggressive type of disease, was only present 17%. Only 26% have high-risk cytogenesis myeloma. I tried to look at these criteria because these really actually determine how good the drug is or not. And I look at the main one is that those patients who were triple exposed was 100%, but those who were triple refractory, 78%, and penta refractory was 30%. Patients' median lines of therapy was about 5 lines, so they were really heavily treated. They have a lot of options that they got, and unfortunately, they were progressing still. Now, looking at the efficacy was impressive, 63% response rate, and that's a good number, for these patients. Complete response and better was around 39%. Now, in my opinion, I think, looking at the duration of response, like these patients stayed in remission, the median duration of response was 18 months. That's very long. And we're talking about patients who are exposed and refractory to most of the treatment. And calling about the median progression-free survival, the results was still great. There was 11 months. So these patients stayed in remission most of the time for 11 months. The median overall survival was about 18 months. So again, comparing to what historically we know about the penta and triple refractory, they survive 5 to 9 months. You're talking about surviving 18 months using the bispecific treatment. And that was really an impressive result for us, especially it's a single agent. So it's an effective treatment in multiple myeloma. Now, we have concerns, and we have to understand and acknowledge the concerns. In anybody who get these bispecific, we have to look at many issues. First of all, hematological concerns, which is the blood counts, white cells, blood levels, platelets. And the other one, non-hematological, which is the acute things like cytokine release syndrome, neurological toxicity. And then we have the delayed problems like delayed neurotoxicity, but worse than that, the infection rate. Everybody knows this is a very bad situation for our myeloma patients, especially using drugs that target the BCMA. So you can see here the hematological toxicity in the grade 3 and 4 was too much, especially the neutropenia, 64%, that requires patients to have delayed in their treatment, or you have to give them growth factor shot, and that led to causes of having more infections for these patients. And you can see that the infection rate, not only all grades, grade 1 and 2, the grade 3 and 4, 45%. A good number of these patients were hospitalized because of the infection. And unfortunately, we're talking about atypical infections like fungal infection, PCP pneumonia, CMV infection were all the major issues that we were facing. Of course, there is other acute issues. I don't think it was really a major issue in our institution, the cytokine release syndrome and the ICANS, although it was commonly to see cytokine release syndrome, but the grade 3 and 4 was very less likely to happen in these patients. So you can see that the majority of the patients have grade 1 and 2, which was tolerable. And you can see the median onset for having it was about 2 days, and the duration barely was 2 days. And the ICANS or the neurotoxicity was only 3 days after the median toxicity. So that was really, I would say, a tolerable treatment. However, we had a low threshold in these clinical trials, as well also in our practice, to give tocilizumab in these patients was about 38%. I think we need to be a little bit careful about that these patients maybe have some fever, low-grade fever. They didn't meet the criteria to really give them, but they were already given for these patients. And I think we just have to have a learning curve about how we do it, because I think this is one of the problems that community oncologists will have about getting reimbursed or not approval, giving tocilizumab in outpatient clinic or in their community oncology clinics. Now, another drug got approved which is elranatamab with relapsed myeloma, and it has kind of like the similar thing as the Majestic study with teclistamab. The focus was on heavily treated patients. They relapsed on many drugs, but they did one thing really good. They look at the patients who never got BCMA-directed therapy, which 123 patients, and patients who actually got CAR T or got the belantamab in that time, 64 patients. And the really good thing about it is that you look exactly if there is any efficacy remaining of a drug that targets the same target that the other CAR T and ADC can target in the past. This drug was also a step-up dose using 76 as a target therapy, and the treatment was given also weekly until they progress. However, the patient characteristics, I will say, was similar to the Majestic study. 25% was high-risk cytogenetics. Extremity was a little bit more, 31%. Patient have bad, bulky disease. However, the triple refractory myeloma was a little bit more, 97%. Penta refractory was 42% of the patients. And the median lines of therapy was about 5 lines. The response rate was about 61%, single agent. Now, this is single agent, which means it was working very effectively without any other drugs. The complete response was about 35%, which is also very great, especially in this stage. And as you can see, the median duration of response for these patients was about, the 15 months was about for all the patients was about 71%. That's really good. For those patients who respond to treatment, have a complete response better, was about 82%. So that's really impressive, especially with this stage, to have this good response. When I look at the progression-free survival for all the patients, at 15 months, it's around, the median progression-free survival is very close to 15 to 16 months. The median overall survival is still not reached, but it shows exactly that these patients also survive, although they're refractory to many drugs in the past. So I think this also was showing the efficacy of 2 bispecific drugs, but we still have the same problem that we had with the teclistamab. What was the problem here is the hematological toxicity. As you can see here, the anemia, neutropenia, thrombocytopenia, and lymphopenia for these patients was very major issue. You can see the grade 3 and 4 was present in about 40 to 50%. That's a big number, like half of your patients are going to be severely neutropenic, and they were going to require growth factor shots, being on prophylactic antibiotics. And that's the reason why we have a higher risk of infection. The cytokine release syndrome, although there was all grades, all of them was grade 1 and 2, 71%, but there was no grade 3 and 4. So it was all treated and resolved for these patients. But as you can see, the infections, especially COVID-related infections, was commonly seen in these patients as well. And I think part of it because of the neutropenia and being very immune suppressed because of this drug. In our real world data that we actually try to evaluate, is that really applicable to our patients who are not eligible for the trial? Because we have to remember in clinical trials, these patients are fit, they're very strong, they don't have any heart disease, kidney disease, but in real world, they do have. So we look at 106 patients who are over 5 institutions, actually. KU was one of them. And the majority of the patients comparing to the other was 25%. Here was about 60% who have high-risk disease, and 42% have extramedullary disease. The majority of these patients were not eligible to the Majestic study, 83%. So that's a big number of patients. They're more frail. They are more have aggressive disease. So we look at the response or the most of these patients, like, I can say that were triple refractory, 92%. So it's a high number. And the BCMA refractory was over half of them. Over half of them were refractory to CAR T and they received our belantamab. So that was something we saw in these patients. The response rate was really impressive here because we're talking about 66%, although these patients have actually progressed on many treatments, but also they're frail and they have been also exposed to BCMA-directed therapy. But if you can see that, those who got high-risk cytogenetics, the response rate was 63%. And that's really a good number that showed you that even with you have a very bad cytogenetics, that's the one thing that we are, we always see very bad response. We saw a great response in these patients. Now, if you look exactly extramedullary disease, that even patients who have very bad disease out of the bone marrow, these patients respond up to 46, close to 50%. Maybe they didn't stay in remission longer, but really they still have a response. So showing that this is a great off-the-shelf treatment that you can give it to patients who have extramedullary disease, like any kind of plasmacytoma in the liver or in the lungs, or pleural effusion, that really can help as well. Now, the number of patients who responded while they were triple refractory was 64%, and penta refractory was 68%. those who are BCMA refractory, because this is a very important thing, especially now CAR T is moving a little bit second line. So now we're going to see more of these patients are BCMA refractory. Our response rate was about 53%. So in translation, the answer is that can you subsequent a BCMA directed therapy after CAR T? The answer is yes. In real world, and as well also some clinical trials that we're going to show you that you can actually use that. So we were very excited about saying that even if the patient got CAR T, the response rate even was better, even comparing to belantamab, about 62% comparing to the belantamab. So our opinion is that when we take a look at that, although the progression-free survival was shorter comparing to the actual data, don't forget these patients are not eligible to the Majestic study. They were very frail. Don't forget that also more than half of them are BCMA refractory. So yeah, 5.4 months, but look at one thing that we're amazing, that there was a line there. There's like kind of consistent that these patients stay in remission most of the time and staying on treatment. The overall survival was not reached, so that shows exactly in real world with this type of treatment, it's really effective in a very good way. Now, the third drug that got approved, and this is something you have to pay attention because there's a lot controversial about it, is talquetamab. I talked about the target about GPRC5D. Now, it's present in myeloma cells, and that's good, it's effective, but unfortunately it's present in the hair follicles and the skin and nails, and that was causing a lot of problems. The designation of the trial was really specifically to evaluate not only the efficacy, but the optimal dosage and the frequency, which I think it's a good thing the company did. And also, they added one thing also, is that the patients who got prior T-cell directed therapy, whether a CAR T or another BCMA T cells like teclistamab or belantamab, they gave them a cohort to actually see and evaluate it. So they studied if this drug can be given weekly, or instead of that, increase the dose and give it every other week. And they also studied if this drug is effective after giving the BCMA-directed therapy prior to. So I don't want to make, talking about the high risk, was kind of like similar to the other studies. The main thing is that all of these patients most of these patients, 70% were triple refractory. And also the belantamab, they were exposed to the belantamab about 9 to 12% of the time. The efficacy I want to focus on is 74%, 73%. That's a great efficacy. That's a number we're focusing on. Like we see that their efficacy in both the dosages, whether you give it every other week or weekly, it was kind of similar. However, when we give the weekly dose, you can see that the progression-free survival for those who got 0.4 weekly was about 7.5 months. And the median duration of response for all the patients who respond was about 9.3 months. When they look at the 0.8, they found out that the median progression-free survival was 12 months, so it was better. And the median duration of response was also longer, 13 months. So they opted to use the every other week instead of the weekly. So it makes a lot of sense because you get better response. But we have bad side effects. This is one of the drugs, although it got approved, I think the side effects were underestimated. And while we think about it, we're not looking at just an infection. Unfortunately, we have seen bad infections, as we talked about, atypical viral infection, RSV pneumonia, all of these stuff, but also we saw other side effects. Skin, lesions that patients have. We have to use some specific creams for these patients, nail dystrophies, and some of these nails are getting out of their places. Oh, no, it's not painful. That was an issue. But also more important, there's other side effects, hematological side effects for these patients. Commonly, we saw this, So commonly, the same problem that neutropenia was there 22% of the time. And also thrombocytopenia 16% and anemia 24% in those who are every other week, although it's better than the weekly, but still was there. The infection rate was not as bad as teclistamab, It's still there, but it's not as 40 or 50%. It's about 11 or 2% that they have these infection rates. So it was a little bit better. But the non-hematological toxicity, excluding the CRS, was the terrible one. I think I just want to say the dysgeusia. I want to mention about that because one of the problems we actually fall on from this trial, they underestimate the dysgeusia and loss of the taste buds that patients have been complaining about it, saying it's a grade 1 and 2. All my patients so far got that, and it was not a grade 1 and 2. It's a grade 3 and a 4, to the point that patients stop the treatment, to the point that it takes, after you stop the treatment, it's the only way to get rid of that. We tried everything, is to stop the treatment or decrease the frequency. And after you stop the treatment, it takes about 3 to 4 months to regain your taste buds. So yes, it is a big issue. It's a quality of life that we're missing. And surprisingly, this was underestimated by the clinical trial, and we're trying to figure out, why is that? And this actually is one of the reasons, although we're talking about 73% efficacy. 73%, it's an effective treatment. Unfortunately, it's not one of the drugs that we use it a little bit upfront. Like, it's my last option for patients. And one of the reasons of that is because you lose the quality of life. Like, if I don't have any other option, this is my option. So this is the last option I give for my myeloma patients in my clinic, because I know they're going to have a very bad quality of life. To the point, I'll tell you exactly one of my patients' experiences saying, this is, you remember my stem cell transplant I got 6 years ago? Yeah, this is worse than that. That's how bad it is. When you say it's worse than mucositis from transplant, and a patient remembers 6 years ago, and he's making that comparison, that's really a bad sign. You have to trust, why are they saying that? I mean, also don't forget they're losing their appetite, and to regain their taste bud back again, it takes about 3 to 4 months. That show you exactly how bad these symptoms can last. So the skin problems, the nail issues was not a big issue in my opinion, or even infection. The issue was the quality of life that got really destroyed by this case. So talking about the post-BCMA era is going to be the big subject. Everybody's talking about what's next. The CAR T have moved second line. We're going to use more of these CAR T cells. What are you going to do next about that? Is it really effective? I mean, our studies internally, the real world data show it was, but also we tried to look at other clinical trials. Does it actually correlate, or we just show some things? So the Orlantinib study, remember that they were actually looking at some studies to see if that is still effective to use post-BCMA. The Orlantinib was used after that. And, I mean, you can see that patients who have high-risk cytogenesis was 30%, and I think, just go here, you can see those who got triple refractory was 96%. Those who are, refractory to both ADC or, the belantamab and the CAR T was over 62%. CAR T, but maybe 11%. So that's a good number of patients, you can see. You can see the results here that patients who are got prior to BCMA, the Orlantinib was working 46% of the time. So it's still effective treatment. That's good. You 46, 50%, that's a good number, that we're saying. It matches what we have. Those who got the CAR T, it was a better response. It was about 53%. And I think there is a theory behind that. The median duration of response for the prior CAR T was 17 months. For the CAR T itself was not reached. And for the median progression-free survival was about 5 months. For the CAR T itself was 10 months. And the median overall survival for all of these patients was about 12 months. Now, I think the theory behind that, why are we seeing that patients who get the bispecific after CAR T, they do better than belantamab? I think the theory is very simple, that when you give the CAR T, it's a one-time treatment. Most of the time, they take 2 years to relapse. So there's that 2 years space, So after that, when they relapse and you give the bispecific, there's more likely there's still going to be some BCMA myeloma cells that the CAR T, the bispecific can attack. Well, if you give the belantamab, most of the time the patients is on a continuous belantamab or a continuous bispecific, and there's no room for, for free of being the drug. So I think that you have less likely the myeloma cells with BCMA. So when you give the bispecific after that, it's even if it respond, it's unlikely to stay in remission longer. So I think maybe that's the reason why patients who get the CAR T, after they get the CAR T and they get the bispecific, they stay in remission longer, which is typically what we're going to do also in our real world. So give patients after they progress on CAR T to give them a BCMA bispecific. Talquetamab, have it been proven? There was a study, and as part of it, 51 patients, that they took those patients who got CAR T or bispecific. The response rate was very good, was about 63%. So it was there. Would I, a lot of physicians came to me and say, well, does it make sense, like if you progress on a CAR T cell, to give a BCMA bispecific or to go to another target? I say, prior to my actual use of the talquetamab when I started using it, I agreed with that. But when I saw the side effects, I have actually pushed it away, and so we started doing more teclistamab or orlantinib in real world after the CAR T because of the side effects. So if I don't have any options, talquetamab is my last option. I know I'm very impressive of the response rate, 63%. It makes more sense to use this drug after the CAR T BCMA, but the side effects is the only thing that is making us very anxious about it. And that's something that we have a lot of question mark about it. So the main issue also we want to talk about that we're going to start seeing more of our patients getting teclistamab or olanzapine, and we're having a problem still. And, it's a very great drug, but it have major side effects. Now, forget about the neutropenia. You can treat it with growth factor shot. It's really the infections that we're actually getting very irritated about it, because now we're seeing infections that we never seen with stem cell transplant. We're seeing fungal infections, CMV reactivations, PCP pneumonia again, that never happened in the past. And I think, the rate of the infections, even some of the clinical trials show 55%, the grade 3 and 4, that these patients require antibiotics, not only stopping treatment and being admitted to the hospital. Opportunistic infection was present in 9%, and 12% of the patient died. I have a patient died from that because she had neutropenic fever and she lived a little bit long, away, and she didn't come, for giving her a shot. So it is actually, unfortunately, a treatment-related mortality that's really a concern for us. The median time to the first onset of infection is very close to 1.7 months. So these patients can have any grade. And the most common, like viral infections, that's the commonest: rhinovirus, influenza, parainfluenza, RSV, pneumonia. The median time to the first onset of infections of grade 3 and 4 was about 4 months. So the longer you keep the patient on treatment, unfortunately, grade 3 and 4 infections can be worse. The only way we can stop this or decrease it is to decrease the frequency, which now recently the FDA, instead of saying, I approve that, instead of doing teclistamab weekly, you can move it to every other week. In our institution, we do it differently. We have been burned out because of the infection, and we are pleased about the response rate. Patients go to complete remission. In an elderly patient, I stop the treatment completely, and I just kind of watch them. They still are high risk for infection, but comparing to being on the treatment often, they're less risky. But there's other things that we can do other than stopping the treatment. Of course, what we can do is that if the patient have grade 3 and 4, watching the white blood cells and a neutrophil counts and giving growth factor shot, I do not hesitate to do that and start them on prophylactic antibiotics. The last thing I want my patient to die from septic shock, which is very easily. We have a low threshold now. If the IgG level is less than 400, even if the patient don't have any infection, we now giving IVIG. Although we were not very interested about that, even with daratumumab and isatuximab, but now we're doing it because the higher risk of infection is the only way to prevent it is to use IVIG in these patients. Vaccination up to date, I'm doing it. I don't know exactly how effective it is. Like RSV pneumonia, I have 2 patients, I gave it to them and still they got the RSV pneumonia, the RSV vaccine, still they got the RSV pneumonia after that. So I'm still keeping my patient up to date for their vaccines in that regard. And we have a very low threshold to stop the treatment if the patient have any signs of upper respiratory infection. So we don't have it's just a cold or just a seasonal cough. We have that low threshold that we stop the treatment and really actually consider antibiotics for these patients. So coming to the last thing is that my conclusion about that, both these BCMA-directed therapy, I like they really actually are very great off-the-shelf treatment. They're really effective treatment. I think the tacrolimus, I have a lot of question mark about, fairly tolerated. After this is that, how can we make it better? We have to ask ourselves what we can do. FDA approved these treatments as monotherapy. So we have to remember that's a very important thing. I called my colleagues in other institutions. Some institutions are adding things, like they like to be creative. I think it's a good idea to be very careful. The drug is it can be very toxic by itself with a high risk of infection. You add an IMiD or daratumumab to that, you double the rate of infection. So you don't want to end up like having a patient dying from an infection that could not be caused. So I will say stick with the guidelines for now until we have really good clinical trials to show as a monotherapy it's really effective. Main adverse events, I think we have hematological, non-hematological. Am I worried about the cytokine release syndrome and neurotoxicity? Really right now, I mean, the CAR T cells are taking most of the heat, not this. It is rarely to see these side effects. I'm not worried about it. The hematological toxicity, I mean, the counts, we can adjust the dose, delay the dose, give growth factor shots. So I think patients are really doing fine and fairly tolerating that well. But the main common thing I'm worried about, the infection, especially in the teclistamab olanzapine, it's very high, 40% grade 3 and 4. That's a high number. And now we're trying to find ways to, improve that infection rate so the patients don't die from that. Talquetamab, I have major concerns. Initially, we were very excited about this results and we're very happy about it. But, when we saw it in real world data about, we have 20 patients, all of them have dysgeusia, all of them. None of them, have been spared from that. Patient with relapsed myeloma, I know a lot of people are scared about, like, if I use the CAR T, is there any other option after CAR T? The answer is yeah. We utilize the teclistamab erlotinib. But to answer a question, if you use teclistamab, will you use erlotinib after that, after it fails, and the opposite is true? The answer is no. It doesn't make any sense. If the teclistamab if it progresses on one bispecific, you're unlikely to respond to another one. So you use one of them, and if it doesn't work, you move on to either CAR T or ADC or something else, or even the last option of talquetamab still makes sense. And future combination therapy, I'll say, we have to be careful about using as a combination right now in real world. I see some colleagues try to do that. I do not recommend that. I recommend just stick with the monotherapy. That's what I recommend. I know some physicians will have their hands on Revlimid and POM, and they will try to add that. Yeah, you will get more efficacy, but you'll get more toxicity in that regard. So I think I can say that was my last slide, but there's questions, right? You asked me. Okay. So I don't know how we present this, ask the question and have answers. So we have, these are actually real world, 65-year-old male patient with known history of myeloma, who is fit, high-risk cytogenesis P53 mutations. We give this patient DAR-RVD induction, stem cell transplant on Revlimid. Patient showed progression disease. What option of therapy you will recommend after the patient progress on the myeloma? Would you consider ide-cel, CAR T cell, BCMA, or cilta-cel, B, or teclistamab, C, or darapomdix, or carfilzomib pomdix? Based on the new guidelines, let's say. And I think I can start with the following, the guidelines right now, I know it's going to be maybe tricky because you have ide-cel and cilta-cel A and B. So people will assume that. So the FDA did not approve ide-cel for a second line. They approve it as a third line, and you have to be exposed to daratumumab, which is in this case, but as a third line. Teclistamab is not approved except after 4 lines of therapy. So definitely this is a second line. So teclistamab is not going to be there. The darapomdix in the study with cilta-cel in the CARTITUDE-4 study was showing it's inferior. So the preference has been always that use something that's superior. So in this case, with a high-risk cytogenesis, the patient's fit, it makes a lot of sense to use a better drug. In this case, it's going to be cilta-cel. Now, the carfilzomib pomdix is not a bad idea. I know some people use it, but there's no big phase 3 trials. But, when we talk about the evidence about cilta-cel versus standard of care, CAR T-cell is better than the standard of care. So in this case, the best answer here is going to be cilta-cel comparing to ide-cel in this case. The second question, if you have a 71-year-old patient, and this is one thing I think we will see it more often, heart failure, diabetes, stage 3 chronic renal failure, came to the clinic, second opinion regarding he have a very high risk cytogenesis translocation 414, got many lines of therapy, and currently on the 4th line. And I as you can see, the regular RVD transplant, Revlimid maintenance, darapomdix, elotuzumab pomdix, and now selinexor Velcade dex. Now progressing with hybrid calcemia. What's your next option to consider? Would you consider just giving off-the-shelf carfilzomib Cytoxan dex? Would you consider a CAR T-cell for this patient, whether it's cilta-cel or ide-cel? Would you consider a bispecific or talquetamab, or sending the patient for hospice? So, see? Okay, I'll do C, and there's a reason for that. If I didn't have C, I'm not going to choose cilta-cel, ide-cel for one reason. I don't think we can get cilta-cel, ide-cel in one, with a patient hybrid calcemia, it's progressing very fast. It's going to take a month to 2 months to have the CAR T ready. So you need something very fast. And, from our results that, you can control the hybrid calcemia, but you can't control the myeloma. So it makes a lot of sense to start something off the shelf. So the bispecific, in my opinion, is making a lot of sense to use it. So I think that's where I will use. If I didn't have it, of course, I will use A, in my opinion, the carfilzomib Cytoxan dex, if it will be very fast to get it under control. but it'll be a lot of concern because of the heart failure and the chronic renal failure. So C makes a lot of, it makes a lot of sense for our case. Some people ask, is it safe to use these drugs in patients on end-stage renal disease? We use it a few times on hemodialysis patient, and really surprisingly, they did well. They didn't have any cytokine release syndrome or neurotoxicity, and they respond really good to the treatment. But I can tell you it's only 3 patients we use it, so it's not a big experience, but I think we will have more and more data about that in the future. But so far, the initial impression about that we're seeing patients who do well on this while they're on dialysis. The last question, I think it's very important. This is actually, in my opinion, very great to ask about a patient have relapsed myeloma, standard risk, have history of recurrent bacterial infection, and got all the treatments, penta refractory, cilta-cel, teclistamab, and now he's on talquetamab. You got the treatment. He's coming here with dysgeusia, weight loss, loss of appetite. What management would you consider for his dysgeusia? A, decrease the dose, possibility change frequency. B, ice cubes. C, nystatin syrup. D, saliva substitutes. Or E, continue treatment and it will resolve by itself. A, I think everybody agrees A is the best answer that we have. I tried everything, even I tried tricks like, lemon and all these stuff, but nothing actually worked. These patients really actually lose the taste, and the only way is that decrease the dose. In my case, if the patient go to complete remission, I stop the treatment and I just wait till their taste buds is back. Do I restart it back after that? The answer is no. And I mean, it's very difficult to convince the patient to go back on treatment and when they relapse, so it's really difficult to do that, even if they respond. So I think that's a big challenge comparing to teclistamab. When we stop the treatment because of infection rate, they're still okay to go ahead and start the treatment if they relapse. But the talquetamab, we are having challenges in that regard. I think that was my last question. I don't think I have one. So anybody have any questions? Yes.
You have to stopping medicine to toxicity, and then if there were a complete response, stopping treatment toxicity, and then re-challenge them if they come back.
If in complete response, we tried it initially, but we stopped that. We just say watch it because we have started seeing that these patients can stay in remission for 6 up to 12 months. So it's a very good, duration of response. So toxicity for other than the talquetamab, the teclistamab and olanzapine, it barely lasts for a month, but they're still in remission. So I mean, it's relatively a new drug, but the longest so far I got is 12 months. I have patients who stay in remission 6 months. So it makes sense just to continue to watch it if they're in remission.
Right, do you have any trials in first line?
We do have, we do have, and it's maintenance, but it's for teclistamab. I think there was an offer to get talquetamab there, and we were planning to do it, then we stopped it because of the side effects.
You're not even.
Teclistamab with Revlimid? Oh, no, we do have that teclistamab with talquetamab, but it's in relapsed myeloma, very refractory, but not in, I would say, not early diagnosed,
And don't you put everyone on back with a cycle of their
We do.
antifungal?
Well-
So you can breakthrough infections on that, don't you?
We do, and unfortunately, they did have that. I mean, back then we put them on that, and we give them IVIG and still they have these infections from the teclistamab. So the only thing we can do is just kind of stop it. So one of the things that we have actually noticed about that, stopping the drug is going to be the best option, especially if they go to remission. But I don't think we do fluconazole if the ANC is normal. The acyclovir definitely do it. The Bactrim we do it, especially most of these patients. CD4 is always low, so we definitely do the Bactrim just to keep them, prophylaxis for the PCP.
So you mentioned the fungal infections.
Yes, yeah.
So we put them on board.
After they got that, yeah. But before, I mean, I think that was, we asked our infectious disease, they didn't recommend that. They recommended specifically some patients, like if they have high recurrence or the higher rate of infection from fungal infection. So we can review that and ask them if this is going to be also a good way to prevent any other atypical infection in the future. And we didn't expect that it's going to be that bad.
When you're monitoring your patients, are you doing that with MRD or are you using
I just use the bone marrow biopsy and the disease markers. We do not, I mean, the MRD we use it in-house. So the flow cytometer MRD, that's what we use for that.
What happened to the bones after bispecific?
The bones,
You did super scan,
like PET scan you're talking about, or what?
PET scan or bone scan?
Oh,
I-
in terms of like, if you're talking about the active lesions, it goes away, but the lesions stay there, but it's not active anymore. So we saw a complete response for these patients. So yeah, the response rate, even imaging studies, it's really good for these patients. Response rate is about 35% for these patients. Some patients, if they have extramedullary disease, it goes away, but unfortunately, it comes back very fast. So we can get them in remission, but we can't keep them in remission, the extramedullary. The bone lesions, I think it's much easier comparing to the extramedullary disease. Yes.
A general, practical question about, you've got a patient who's starting on a bispecific like this, and let's say 1 month later after starting therapy, so they're developing fever. You've got multiple different things on your differential rate. They've got CRS risk, they've got serious infection risk. How do you kind of practically approach that, when you have someone in that situation? I know, when they're hospitalized, we're typically empirically covering for everything, treating CRS, that type of thing. But you guys have an algorithm or approach when you have someone with fever?
Absolutely. Yeah, I think that's what was a very important question for us. So typically the CRS, we see it in the first week, unlikely we'll see it afterwards. If we see it afterwards, there's a lot of question marks out there. That's kind of atypical. And most of the time the CRS, as you can see, grade 1 and 2. Our protocol in the hospital, and hopefully we're going to start every patient's outpatient, we're going to try to do it. We treat the fever as CRS, but also we treat it as an infection protocol. So we have to cover these two things. So you see patients although they don't have the rest either, they don't have any infection symptoms, but they start with antibiotics for some reason. They do the blood cultures, and once everything is negative, they confirm, okay, it's a CRS that these patients have. So we do that. If they come after 1 month with a teclistamab or imatinib and having fever, that's absolutely an infection workup that we do. We are careful about that. We do the all workup. What exactly are symptoms, if they need to do RVP and all these stuff. And chest X-ray or CT, in this case CT scan of the chest. Make sure that they don't have any signs of sepsis. So we have a low threshold about treating them for infection, and mostly we admit these patients to the hospital just to make sure that we don't under treat them as an outpatient.
So at the lower threshold, start steroids and other things beyond the first week when CRS
Yeah.
is low.
And it's unlikely. The first week, definitely we know it's going to be CRS more than infection. We will still treat it, but after 1 month, it's unlikely. And we don't treat with steroids after that. We try to stop any steroids or pre-medications after that because we don't want the steroids to affect the T cells and cause depression. So that, the bispecific will be very active in these cases.
Other questions?
Okay.
Thank you, Dr.
Thank you.
So just a few updates of our upcoming events that I wanted to share with you. So our annual mid-year review, formerly our ASCO review, will be held Saturday, June 22nd from 7:30 a.m. to 2 p.m. Please note the change in location. Usually we host it here. We were not able to this year, so we'll be over at the Embassy Suites in La Vista Conference Center. So don't be here at 10:30 a.m. We won't be here. And then our next few speakers will be our evening speaker series will be skin cancer update on Tuesday, August 27th, same time, same location. And also our lung cancer update evening speaker series event, again, here on November 7th, from 5:30 to 8 p.m. And with that, thank you again for all of you guys' attendance tonight and your participation and your great questions. And we hope that you're able to join us. Learn more about our events at nebraskaoncology.org/events. All right, have a great evening, everyone.